Thank you, madam, for that kind introduction. The last talk, I'll quickly try to wrap it up. Uh, the topic given to me is genetics of cardiac disorder. If you take the cardiac lesions, which has the genetic contributions, there are various types of cardiac lesions, including structural heart defects, valvular heart lesions, aneurysms, cardiomyopathies, heterotaxis, arrhythmias, and other late onset uh, cardiovascular diseases, including coronary artery disease, congestive heart failure, which might have a genetic contribution. So today I would be talking with some case illustrations focusing on structural heart defects, valvular heart lesions, and bit of cardiomyopathy. So coming to congenital heart disease, incidence is 4 to 8 per thousand live births. Incidence further increases if we include tiny trivial lesions like bicuspid aortic valve, prenatally diagnosed spontaneous abortion, stillbirths with congenital heart disease. And the severe congenital heart disease, which includes single ventricles, conotruncal heart defects, AV canal defects, which the incidence is around 2 to 3 per thousand live births. So as we know about the developmental pathways of the heart, there are a whole lot of new pathways and transcription factors, epigenetic factors, which are involved in the embryology of the heart. Now, we know that the same gene mutations can cause both isolated and syndromic congenital heart disease as well as cardiomyopathy, and also there are late and varied effects of the same genes. So indicating genotype-phenotype correlation is not that simple. So as any other birth defects, congenital heart disease is etiologically highly heterogeneous, which include chromosomal single gene, epigenetic alterations, somatic mutations, and gene-gene as well as gene-environmental interactions. So as any other birth defect, we try to classify them as syndromic and non-syndromic. Coming to isolated congenital heart diseases, majority have been thought due to multifactorial inheritance. Increasingly, now we know they could be due to single gene origin and as well as due to copy number variants. So the same genes can cause same genes like single genes can cause isolated congenital heart disease as well as syndromic congenital heart disease. For example, TBX5 can cause Holt-Oram syndrome as well as isolated septal defects. So currently, we don't do clinical genetic testing for isolated congenital heart disease, except for some severe congenital heart disease like conotruncal heart defects or familial CHDs. We can offer genetic testing, but however, we should counsel the parents about the low diagnostic yield and rarely clinically useful. So these are the various genes described in isolated congenital heart disease. Now we have growing adults who have been operated at young age, coming for counseling, premarital counseling, or CHD associated with some learning difficulties, and we do genetic testing as and when required. So adults with congenital heart disease, their growing number due to good medical and surgical care, and their need is different from the children um, in terms of specialty care, lifelong specialty care, psychosocial problem, extra cardiac manifestations, infective endocarditis, reproductive issues, etc. And also, it is important for pregnant women with congenital heart disease who are planning to have babies. So coming to syndromic congenital heart disease, chromosomal, it ranges from 5 to 25% based on the period which we talked about earlier. When the chromosomal microarray is not there, chromosomal disorder accounted for 5 to 12% in the newborns. If fetus were included, it was around 30%. With the molecular techniques, then we know now that chromosomal causes with microdeletions and microduplications, it might go up to 25%. So common trisomies with congenital heart disease, Down syndrome, trisomy 18, trisomy 13. Trisomy 21, the commonest cardiac lesion is AV canal defect. With good medical and surgical care, lifespan has improved. As an adult, they might be at risk of having valvular heart lesions. If symptomatic, they need to be screened. Whereas trisomy 18 and 13 carries poor prognosis. Most of them die by 1 year of age. Even if they survive, it is associated with severe mental and physical handicap. Generally, surgery is discouraged. Turner syndrome. The commonest cardiac lesions include left-sided cardiac lesions, as well as they are at risk of acquired cardiovascular abnormalities. So these are the various uh, congenital as well as acquired cardiovascular abnormalities. The commonest cardiac lesion include bicuspid aortic valve and coarctation of aorta. Even if the initial cardiac evaluation is normal, a child need to be screened every 5 to 10 years at transition from adolescents to adults before pregnancy and throughout the pregnancy, and adults every 3 to 5 years as they are at risk of having aortic root dilatation and dissection. So the other group of common commonly associated with congenital heart disease is microdeletions and microduplications, where conventional karyotype can't identify these microdeletions and microduplications. The size is usually less than 2 to 4 MB. We have targeted testing like MLPA and microarray can be used. So these are the children with congenital heart disease, facial dysmorphism, which includes bulbous nasal tip, small mouth, cleft palate, slender long fingers, and cup-shaped ears, collectively earlier known with different names, and now we know these are all due to 22q11 microdeletions, where different types of tests can be used: FISH, MLPA, and microarray. Microarray is preferred because it gives the size of the deletion, which can be useful in genotype phenotype correlation. So sometimes it could be a familial. 5 to 10% of these 22q microdeletions are familial, which is usually the size of the deletion is small in these familial cases. So irrespective of clinical phenotype, parental testing is indicated. So the risk of recurrence can range from 0 to 50% based on the parental status. So the commonest cardiac lesion in these 22q microdeletion is conotruncal heart defects, which includes tetralogy of Fallot, aortic arc anomalies, truncus arteriosus, VSD, pulmonary atresia. So there are anticipatory guidance, which includes in 22q deletions, hypocalcemia, uh, which is most commonly seen in neonatal period, but can happen at any age. So they require calcium monitoring, especially during acute illness and perioperative period. And majority of them have learning difficulties. Other features include otorharyngeal abnormalities, psychiatric disorders, and other rare manifestations like renal anomalies and clubfoot. So whenever we have a child who is undergoing surgery with DGeorge phenotype, there are certain guidelines for the intensivist: perioperative calcium monitoring and supplementation, use of irradiated blood products and CMV seronegative blood components because of underlying immune functional abnormalities, which can be partial or severe. In these severe cases, live viral vaccination are contraindicated because of lethal infections. And sometimes these partial diabetes syndrome can behave like severe because of certain underlying uh, immune phenotype. So as discussed by Dr. Ratna, madam, the chromosomal microarray increases the diagnostic yield in any birth defect, uh, which leads to accurate genetic counseling. Coming to single gene disorders, which can be around 5 to 26% of CHDs carry single gene mutations. The presentation can be multiple malformation as well as isolated congenital heart defects. So these are the common syndrome. Noonan syndrome is one of the commonest single gene disorder associated with congenital heart disease. Commonest cardiac lesion being pulmonary stenosis, followed by hypertrophic cardiomyopathy. And intelligence can range from normal to mild intellectual disability, which can be seen in 15 to 35% of the cases. So there are many Noonan-like conditions, like postulo-cardiofasciocutaneous syndrome, Noonan syndrome with neurofibromatosis. Now we know that all collectively these are called as rasopathies, which are caused by this particular mutation in this particular pathway, that is RAS MAPK signaling pathway. So these are the Noonan syndrome molecularly proven with different genes in the RAS MAPK pathway. So now genotype phenotype correlation is emerging. Now we have mutation specific follow-up, and they can be autosomal dominant as well as rarely autosomal recessive inheritance. And then now we have newer therapies based on the underlying genes. Genotype phenotype correlation includes PTP-N1 mutations most likely to have pulmonary stenosis, followed by they can develop a hypertrophic cardiomyopathy age dependent. So they need to be followed up once the pulmonary stenosis is corrected. RAF1 mutations most likely to have hypertrophic cardiomyopathy. SOS1 mutations most likely to have valvular dysplasia, and uh, SOS2 mutations most likely to have ectodermal findings. So coming to valvular heart lesions, the commonest condition is, and aneurysm commonest condition is Marfan syndrome. Most of them are familial. 25 to 30% cases are sporadic. See, the Ghent diagnostic criteria, which is used in adults, but in child, it is difficult to use because of age-dependent clinical manifestation. Best discriminating factor include ectopia lentis, aortic root dilatation more than 3 standard deviation, height more than 3.3 standard deviations, which can classify Marfan syndrome in children more than 90% accurately. So these are the clinical features, diagnostic criteria. Skip this. This is autosomal recessive Marfan syndrome, rarely described with more severe phenotype compared to the parents. These are the differential diagnosis where you can, there are Marfan related disorders which involve TGF beta signaling pathway, or Marfan-like overlapping connective tissue disorders like Ehlers-Danlos syndrome and homocystinuria. Pharmacological protections include losartan and beta blockers. Either both of them are equally effective. There are many ifs and buts about these drugs. If you use losartan, add beta blockers if it is progressing, and combination are always better in even in children. I'll skip these things because lack of time. This is lethal arteriopathy with homozygous, commonly described in northern part of Kerala, called as Mapilas. So we find the same child coming from Mysore, unrelated patient with giant aneurysm, indicating endogamy, homozygous mutation, indicating endogamy. This is autosomal dominant disorder with variable expression. Mother having short stature, one child having CHD, the other child having esophageal atresia. The diagnosis is mandibulofacial dysostosis given Almeida type, indicating clinical variability, dominant disorder with highly clinical variability, making genetic counseling challenging. Coming to cardiomyopathy, they could be hypertrophic, dilated, restrictive. Inheritance could be dominant, recessive, X-linked, mitochondrial. And these are the various diagnostic yield ranging from 10 to 60% depending upon the types. In children, we need to do the investigations for syndromic as well as metabolic disorders. So utility of genetic testing in cardiomyopathy, penetrance, clinical variability, many private mutations, background modifying genes, epigenetic environmental factors complicate the clinical utility. But managing strategies like periodic evaluation, extended family member screening, genotype-based management like laminin A-associated dilated cardiomyopathy, more likely they will benefit from pacemaker and ICDs. So that's the utility. I'll just end up with this treatable cause of hypertrophic cardiomyopathy. Enzyme replacement therapy was used in this child. Infantile Pompe's disease, doing well on ERT. And the other, the last siblings with NEX1 gene mutations indicating mother is the carrier for this mutation, indicating incomplete penetrance, and or it could be an age-dependent expression which ranges from 0 to 67 years. Thank you.